Next thing we'll do is to talk about management of heart failure. So what is acute heart failure? And so this talk will be separated in between acute heart failure management and chronic heart failure management. So acute heart failure is the onset of symptoms that may be sudden or gradual. And patients may have, as we've talked about, shortness of breath, edema, chest pain, orthopnea, paroxysmal nocturnal dyspnea. But what we do know is that pulmonary and systemic congestion are nearly universal. Patients may have lethargy, abdominal pain, or anorexia. And acute heart failure leads to unplanned office visits, ED visits, and hospitalization. This is a general helpful classification scheme of where a patient may be on the scale of heart failure. So we think about two factors. One, are they volume overloaded or congested? And then two, are they perfusing? Are they warm or are they cold? So A is where we want our patients to be. We want them to have normal perfusion and no congestion. So hopefully we're all sitting right about here right now. A patient who has volume overload but is nice and warm and well perfused and has good end organ function is sitting here. A patient who has no fluid but is very cold because of low output would be sitting here. And then a patient who has lots of fluid but is also cold is here. And so we want to be thinking about where our patient is on this axis because that will help us to determine what course of action to take next. How do we assess perfusion? So a very simple way is to simply feel the patient if they're cold or warm, but not every patient will manifest this clearly. If the patient's mental status is diminished or they seem confused, that may be a manifestation of low output to the brain. Patients who have a narrow pulse pressure, pulsus alternans, low serum sodium, or they may be diuretic unresponsive or have evidence of end organ dysfunction like kidney dysfunction and liver dysfunction. So the major treatments for acute heart failure are diuretics, vasodilators, and inotropes. These are treatments to get patients feeling better and to improve perfusion in the short term. After we talk about this, we'll talk about the chronic management of heart failure that improves survival. So in terms of diuretics for the patient who comes in congested or volume overloaded, the general recommendations are that patients promptly be treated either in the hospital or in the clinic setting with IV loop diuretics. And that the dose given should be adequate to actually induce diuresis. If the dose that's given originally is not sufficient, it should be increased, or a second diuretic like a thiazide diuretic should be added. In general, the data to promote the use of a low-dose dopamine infusion is relatively poor, which in the American Heart Association, American College of Cardiology recommendations only received the 2B recommendation, which is to say the data is not very profound. You can do it, but it may not work. Diuretic dosing in states of heart failure, higher doses are often required to achieve the same diuretic effect. So for a normal patient, at a given diuretic, we will see more diuresis than in a heart failure patient. Often patients with heart failure will have difficulty responding even to very high doses of diuretics. So what can we do to try to help our patients more? So if we think that the reason for diuretic resistance is related to low cardiac output or decreased renal blood flow, then we may need to start an inotrope to augment contractility to decongest the patient. If we think that it's because of decreased nephron responsiveness, we may increase the diuretic frequency. If we think that it's due to decreased tubular transport, we may increase the diuretic dose. And if we think that it's because of an increase in distal nephron compensation in the distal collecting tubules, we may add a thiazide diuretic. So the second treatment strategy after diuretics would be vasodilatation. And these are medications that have been used for a very long time. So the VA cooperative study in 1982 looked at the role of nitroprusside versus placebo. And nitroprusside is known to have an effect on afterload reduction, which may lead to a higher cardiac index and output and lower filling pressures. This was an interesting study because at that point in time, nitroprusside was known to worsen mortality when given after a heart attack. But in this study, there was no change in mortality. And so patients may feel better when we give this. We're certainly not improving their survival, but they may feel better. So the recommendation is that IV nitroprusside may be used in patients to help decongest them and make them feel better, as long as they don't have severe aortic stenosis or mitral stenosis. Thinking about vasodilatation in real life, I think it's very instructive to think about what happens at the hemodynamic level in these patients. So this is an example of a patient who's in heart failure with numbers that we might see if we were doing an invasive measurement of hemodynamics with a Swan-Ganz catheter in the cath lab. So this patient has an RA pressure of 15 millimeters of mercury, PA pressures of 55/30 with a mean of 40, a wedge pressure of 30, which is very high, normal should be around 5, and a cardiac index of 1.78, which is low. Anything under 2 is frank low output. And an SVR, or systemic vascular resistance, of 2200, and that's in part because of activation of the renin-angiotensin-aldosterone axis. So this is sort of a classic patient who I might see in the hospital who's being admitted for shortness of breath and perhaps some renal failure and pulmonary edema and elevated JVP, who very much so needs some treatment. And we can do something called a NiPride study, where we give the patient an infusion of nitroprusside as high as their systemic blood pressure will allow. And we see almost immediately in patients who are responsive to vasodilators, and not all will be, that we see a decrease in their filling pressures, which in turn helps to increase their cardiac output without ever starting an inotrope medicine. So simply with vasodilatation and reduction in SVR and reduction in filling pressures, we can see an improvement in cardiac output. So this would be what my colleagues and I would call a good study, where we see all these things. A bad study would be somebody in whom their systemic blood pressure would be too low to tolerate this afterload reduction with vasodilators. Which gets us into a state where we often need to consider the use of inotropes, which are a temporary solution for a low flow state. Who should we consider using inotropes in if the patient has worsening renal function but still is volume overloaded? Anybody who is manifesting end organ dysfunction, patients who have evidence of elevated lactate, which again is a manifestation of poor end organ function and low blood flow to the periphery, and people who have an altered mental state that we think is due to low flow, not something else. All these factors may be a sign that our patient is either going into or is already in cardiogenic shock or a profound low flow state. So how do we choose which inotrope, which is going to augment contractility in our patients? How do we choose which one? And depending on where our patients are, we may only have access to one type of inotrope, but we may be able to choose, and sometimes the patient will help us choose. So for example, a patient who has a very low blood pressure may not be able to tolerate milrinone because it's more profoundly vasodilating. And so we would choose dobutamine in that patient. In a patient who perhaps has an increased heart rate, we know that dobutamine is going to cause an increase in the heart rate more, so we may choose milrinone. All of these medications have vasodilatory effects, dobutamine and milrinone. Epinephrine and norepinephrine will be vasoconstrictive. So moving on away from acute heart failure management to chronic heart failure management, we're thinking about medications that are going to improve heart failure survival. So this would be beta blockers, ACE inhibitors, aldosterone blockade, and hydralazine and iserdil. And so here are listed some of the landmark beta blocker trials that have occurred over the last 30 years, starting with Copernicus, Merit, BEST. All of these show that survival is improved using beta blockers in a patient who's compensated. And I think that's a critical distinction to make, that if a patient shows up to us in a low flow state who's volume overloaded, that's not the time to initiate a beta blocker. Beta blockers should be initiated when the patient is compensated, euvolemic or dry, and is not manifesting a low flow state. This is just another slide showing the beta blocker trials in the United States. So which is the best beta blocker to choose amongst a group of many? The beta blockers that have been studied and have been shown to improve survival in patients with heart failure are carvedilol and long-acting metoprolol. Bisoprolol and bucindol have also been used, but carvedilol and metoprolol XL are generally the ones that we use here. ACE inhibitors in numerous studies have also been shown to reduce mortality in patients with left ventricular dysfunction. And this is just a meta-analysis of 5 trials involving over 12,000 patients with left ventricular and diastolic or left ventricular dysfunction, followed for 35 months. You can see here that the cumulative mortality was lower in patients who received ACE inhibitors, and that decrease was seen as far out as 4.5 years. Aldosterone blockade is another important cornerstone of how we decrease mortality in patients with heart failure. And this is a representation of how aldosterone blockers help to decrease aldosterone, which can help reduce salt and water retention, and also perhaps have some impact on fibrosis in the heart in terms of reducing fibrosis. And the RAIL study is probably the oldest study in 1999, looking at spironolactone. And RAILs, this was in patients with more significant heart failure symptoms, but they had about a 30% risk reduction of death with the use of spironolactone plus standard therapy. Ephesus looked at the use of eplerenone in patients with heart failure after an MI, and eplerenone also was associated with a reduction in mortality or an improvement in survival after heart attacks with concurrent heart failure. Finally, outside of the medicine world, there are devices that have been long proven to have an effect on survival, primarily defibrillators, and in well-selected patients, biventricular pacemakers to induce cardiac resynchronization in patients with left bundle branch blocks or very prolonged QRS intervals. So that is our discussion of management of heart failure.